mean, I understand that this is a Saturday morning and you guys are very brave to waste one of your Saturdays before Christmas listening to this. So I'm going to try to make it as light as possible. I made sure that any medicine that I cannot pronounce the name, I'm not going to include in my slides because I don't want to make a fool out of myself. But I'm really surprised that they assigned this topic for me, because this is becoming the most important liver disease that we deal with nowadays. You've heard Dr. Hassanein saying that hepatitis C is going out, and we're going to end up with fatty liver as the major health issue that patients with liver disease are facing. Let me just tell you, why did we decide to call it this funky name, non-alcoholic fatty liver disease? Or sometimes they call it NAFLD or NAFLD, or sometimes they call it a certain part of the population with this disease are going to be called patients with NASH. So why did we call it this way? We called it this way because if we decide to take a biopsy from the patient and look at it under the microscope, the pathologist cannot tell the difference between somebody who has a liver disease from alcohol and a liver disease because he's eating too much. It's the same kind of histologic change, the increased amount of fat in the liver, which we call steatosis. It's the presence of inflammatory cells, bridging fibrosis, Mallory bodies, cirrhosis, all those kind of fancy names that goes along with the pathology report. It is the same whether the patient is drinking alcohol or whether the patient has his liver disease from eating too much. So I want you to be aware of the fact that non-alcoholic fatty liver disease is not only one presentation, and it's not only one group of patients. In its mildest form, it is just nothing but steatosis, nothing but building up of fat inside the liver. And as a matter of fact, the vast majority of the patients that are going to be referred to my office are going to be only having fat deposited in their liver. Would this damage the liver on the long run? Possibly. So I want you to be aware of that not everybody with excessive amount of fat in the liver is going to end up with damage, inflammation, scarring of the liver, and cirrhosis eventually. So those are the two extremes. You're going to have only patients with fat in the liver, and you're going to have people in the middle with fat and inflammation. We call those the group of non-alcoholic steatohepatitis, and that's the term that we take the name NASH from. So you'll hear that somebody was diagnosed with NASH, and those are the patients who are likely to progress and eventually develop cirrhosis of the liver. Okay, so just some pictures on the top left part. This is a liver that has only fat, and if you look at the biopsies, the cells are ballooning and they look white because when they are preparing the slice, the fat will dissolve and will leave an empty space, and that's why you see all those empty spaces where it says steatosis. And then you get into a more advanced stage in some patients, not in everybody, in which there will be an ongoing inflammation in the liver. Okay, and that's called steatohepatitis, and that's the picture that if I take these slides and give it to a pathologist, the pathologist cannot say if this is from fat in the liver or this is one of those patients that Dr. Hassanein was talking about with alcoholic hepatitis. It's exactly the same picture. And then eventually the disease is left untreated, the person would end up with cirrhosis of the liver, which is this picture down here, and you do have what is called regenerative nodules of the liver. So you start to see like little balls under the slide, or little circles, and those are the result of scarring of the liver, and that's what impairs the circulation going to the liver, and that's what is responsible for all the problems that we see in patients with cirrhosis, from the buildup of fluid to the bleeding from esophageal varices to the hepatic encephalopathy and getting confused and things of that sort. All of that is happening because you are disrupting the circulation of the liver. And then in a smaller number of patients, you're going to end up having liver cancer. So those are the stages of fatty liver disease, as I mentioned, and I want this to be very clear in your mind. Not everybody who would start with accumulation of fat in the liver is going to run through this course and end up with either cirrhosis or hepatocellular carcinoma. Okay, so if that's the case, let me show you a picture that will stop you from eating right now. Because those are two livers that were taken from donors, and they are going to be put into somebody who's going to receive a liver transplant. So sometimes a donor is chosen, and when they take the liver out of his body, the liver looks that yellow, fatty liver. Okay, it's a healthy liver. It's not cirrhotic. You can tell from how smooth the surface is, but the liver is packed with fat. And the interesting thing is, this is what we do to generate foie gras that we enjoy eating, which is force feeding, ducks, so we can pack their liver with fat. So when we cook their liver and we taste it, it tastes very delicious. And we've had foie gras, and you end up, paying a hefty bill for that. But that's what we are doing to our liver. We are force feeding ourselves to develop this degree of greasiness of our liver, and that's gonna obviously come with a price. Now, why is this happening, and why is this becoming the most prevalent disease in the United States? Let me tell you that the most common reason for people to have abnormal liver tests nowadays is fatty liver. The most common referrals to my office for liver disease is because of fatty liver. Fatty liver is currently the second common listing for liver transplant, and pretty soon is going to be the number one reason why people are put on transplant lists. It's because of fatty liver disease. That is happening in the time when hepatitis C is coming down, when alcoholic liver disease is pretty much increasing at a very slow rate. Fatty liver listing for liver transplant is increasing by 170% in the last 4 years. So that, you might say this is really crazy, and I'm glad that there's only 2 people in this room who are in their early years of life, so they are only 20s, but most people here are, over the age of probably 35, I would say. Sorry if I insult anybody. But I don't know if we remember as adults, if we have ever seen this amount of obesity around us and this amount of overweight around us. You look at the maps from the United States showing the percentage of obesity, and you look, this is not the early 20th century, this is 1990, and look what happened every decade as far as the amount of obesity in the United States. Now, when the colors are blue, that means that the obesity was like less than 10% of the population, less than 15% if it's dark blue. And look what's happening nowadays. You can hardly ever find one state that has a blue color. I think this is probably Colorado, that the one, I'm not 100% sure, the one that is still showing obesity of less than 15%. But interesting thing is, California is really one of the lead states, and that came as a surprise for me because I see a lot of obesity around me. But the bottom line is, the United States nowadays, obesity rates is 30%. It is unbelievable. We are the number one country in the world in the obesity rates. And this is only happening in the last 20%, so we have to stop and ask ourselves, what did we do to ourselves in the last 20, 25 years, 30 years? And the answer to this question is, when you leave here today and you're driving down the road and you're going to see the number of fast food chains around us, and that is the culprit. That is what is poisoning our bodies. And they train us from early years of our lives. They associate the Happy Meal with the toy, with their food. And that's how they are training our taste buds from early on, giving us all the sweet stuff, giving us all the fat in the food, because fat is what makes our food delicious and sweet is what makes it sweet. And after you try this food for a while and you try to eat a plate of salad and you're gonna tell yourself, this is rabbit's food, this is not meant for human beings. And why? Because we are trained to like their food from very early years of our lives. This is high school obesity by state, 2015. So the problem is starting early on in life, and we can all attest to this. We all see kids nowadays who are overweight. And if you look at this, I mean, like 15% obesity rate in high schools in different states. The problem is starting early on in life, which means that we're going to end up with liver disease younger and younger and younger. Okay, it's not a problem in the United States, it's a problem all over the world. That's why the title said it's a global threat. You look at European countries, and European countries did not used to have this issue of obesity in the past, but now if you look, you will find that different European countries, it goes up to 20% obesity rates. And if you compare countries from different parts of the world, you always find the United States as the one that has the highest obesity rate, but everybody else. And that's also an interesting thing to look at, because, I mean, some of those countries really don't have the same economic success that the United States and the European countries has, and the income of people is not very high. So we have to ask ourselves, how is obesity so common in countries that don't have this standard of living? And you guys, if you want to know the answer, it is what we call corn syrup. And it's not that expensive, and it's used very commonly in preparing our food. They use it to prepare our food because it adds volume, it adds it improves the texture of the food, it makes it softer, it make it taste more fresh because it increases the amount of water in the food, and it also enhances the flavor of the food. Okay, so this is the corn syrup that they are feeding everybody in their products. And you know, if you go to any country in the world, you're going to find a McDonald's, and you're going to find all the fast food chains spreading across the globe, and their local competitors will learn the same practice, and they will feed the people with the same kind of food. If one of the professors of my son tells his student that the most common source of carbon in the human body nowadays is coal. So if we analyze you, the most common source of carbon in our cells is coming nowadays from coal. And that's what we're eating. Now, if that was shocking, look at this. This is, so when you're saying obesity, you're saying people with body mass index of 30, BMI of 30 or above. If you look at overweight and obese, which means that you're starting from a BMI of 27, can you imagine that 74% of people in the United States have a BMI above 27? Which means out of 4 people that you're going to meet, only 1 person will have a healthy body weight, and 3 out of 4 are going to have either overweight or obese. To the degree that when people look at me in my office and they say, oh, we can't understand how you keep yourself thin all the time like this, and I'm telling them I'm overweight. I'm not healthy. My BMI is about 28. So which means that I'm at risk of developing this thing. But the picture has changed so much that even an overweight person nowadays looks slim, and that's how bad it got. So overweight, it's 2/3 of the people are becoming overweight nowadays. Not only here, in different countries as well. Anglo-Saxon countries, 60% of them are overweight. So what is the reason, guys? I mean, I was not in the United States before 1982, so I don't know how they were serving burgers and sodas back in the 50s. But according to this slide, that between 1950 and now, everything tripled in size. So it's not only that they are using a lot of sugar in our food because corn syrup is sugar, they are not only using more fat and more corn syrup, but they are also supersizing the size of the meal. So if you go and your plate is not that big and you leave the restaurant, you're unhappy with that restaurant because they really didn't serve you well. They didn't give you enough food. You get out of the place and you're still hungry, okay? But in reality, we are eating a lot more compared to what our parents and grandparents were doing. And this is the result. The result is truncal obesity, so you end up with people who have waist size that is much bigger, and this is the kind of obesity that is going to be associated with fatty liver disease. So what is the prevalence of this disease all over the world? 25%. You can take this number and say that 25% of the population of the world now, they have fatty liver disease. When I was preparing the slide and looking at it, and I looked and they said that the highest incidence of fatty liver disease is in the Mediterranean or Middle Eastern countries. And I looked at it and I said, okay, so how am I going to convince the audience tomorrow that the best diet that people should have is the Mediterranean diet? If this region in the world has the highest incidence of fatty liver disease. And the only answer I could come up with is people over there, they are not eating Mediterranean diet. They are eating something different. They changed their eating pattern. Okay, and all of this, guys, you can trace it down to the amount of sugar that we are eating. Adams, my son professor, tells him in the lecture, we are eating crap load of sugar. And we are truly doing that. We are eating tremendous amount of sugar every single day in our life, to the degree that he tells them that statistics showed that at the beginning of the 20th century, an average US citizen was eating 3 pounds of sugar per year. And nowadays we eat more than 100 pounds of sugar per year. So this is how we changed our eating pattern. We don't obviously eat sugar, but we are eating things that become sugar eventually, and most of it comes from corn. Now, so obviously I was surprised that California is a lean state, but if you look at fatty liver, and if you look at the ethnic backgrounds of people and whether all men are created equal or not, and the answer is no. In the Hispanic population, the incidence of fatty liver disease is very high. It is much higher than in blacks, for example. And white men, incidence is probably closer to the Hispanic population, and white female is probably half of that. So there's something in the genes of people with Hispanic heritage that would make them more susceptible to obesity and to fatty liver disease. And there is a lot of genetic influence. There is a group of people called the Pima Indians. Pima Indians lived all their lives in deserts. Their food was scarce. They developed a thrifty gene, a gene that will help their body to retain any kind of food that they eat and build with it and stay healthy. And when we expose the Pima Indians to the Western diet, 80% of them are going to become obese and 80% of them are going to develop diabetes. So there's something in the genetics in the Hispanic population that makes them more susceptible to getting fat and fatty liver disease. There are other associations of fatty liver disease. We see it in people who have what is called the metabolic syndrome. So people who have high triglyceride level, the hyperlipidemia, people with hypertension, people with diabetes or insulin resistance, and people with the truncal obesity, if you remember that picture. People who have those kind of things are likely to have fat in their liver. So when we ask ourselves, how are we going to diagnose our patients? Because we really not unlike hepatitis C, in which there is a blood test that tells us that this patient has hepatitis C, we don't have a blood test that tells us this is fatty liver disease. So, but we build our suspicion for the presence of the problem based on associations. And if we have a patient who have any of those things that we call the metabolics, if you have two of these, we call them metabolic syndrome patients, If you have any of those conditions, you start to suspect presence of fatty liver disease. And that's why it's important for us to educate our colleagues who treat patients with high blood pressure and diabetes to start looking for fatty liver disease. The severity of fatty liver disease will increase with how many of those metabolic syndrome factors the person would have. So if you end up with diabetes and high blood pressure, almost 70% of the patients who have those two combinations are going to end up with excess fat in their liver and fatty liver disease. Now again, I want you to remember this because this is really important. I don't want you to think that we're gonna all die of liver disease within the next 10 years, because there are the vast majority of people who start with fat in the liver, which is this part of the pie here. This vast majority of people are going to stay with fat in the liver, and they are not going to get any worse than this. There is this much that will get better, and there is this much that will progress to develop fibrosis and cirrhosis of the liver. So this is the bottom line. I don't want you to feel like everybody who is diagnosed with fat in the liver is going to end up with cirrhosis and cancer. So that's why people think that maybe this is a disease that requires two hits or two sorts of injury. So the first hit is what we do to ourselves. The first hit is overeating. When you're overeating, you're taking all that sugar and you're converting it into fat in the body. We have a way of doing that. That you take the excess sugar that your body doesn't need. You've already generated the energy, the ATPs that your body is going to be using for the daily activity that you are doing. And if you're eating more than that, then your body is going to shuttle that sugar, is going to shuttle it into fat and store it as fat. Okay, that's how we are built. So this is the first hit. We do it to ourselves. We don't exercise and we eat too much and we end up with fat in the liver. And then the subset of patients who are going to start having inflammation, who are going to have scarring, who are going to have cirrhosis, who are going to have cancer, they must have a second hit, a second insult that damaged their liver. What is that second insult? If I show you a slide, you're not gonna like me because basically we don't know. And because we don't know, we have so many possible contributions for this and that. It's like the slide that Dr. Hassanein showed you that showed that liver cells with tons of writing on it. And so we don't know what drives the cells, but we know it's a very complicated process. We know that it must also involve the bacteria that we have in our intestine, and not all of us have the same amount or variety of bacteria. We are all different when it comes to the bacteria that lives in our intestine. I also want you to remember one thing, is the only thing that has been proven to prolong life is calorie restriction across all species. And they say if you eat 30% less calories, you live 30% more years. So this is only in humans. This is in human, primates, this is in worms, this is in yeast. Anytime you want to make something live longer, you give them less food. So what is the relationship between eating too much and dying young? It is because we are overworking our mitochondria. So the mitochondria is the part of our cells that is responsible for generating the ATPs, generating the energy that our body is going to use. So anytime you're eating, you're using your mitochondria and you're using it a lot. So it's like a car. If you're going to take your car and you drive it 12 hours every day, you're bound to have things going wrong in your car. And if you eat too much, you end up hurting your mitochondria. When you start hurting your mitochondria, you start causing malfunction of the mitochondria. So the mitochondria will start generating toxic compounds inside your body that they call ROS or reactive oxygen species, and all of those ROS are going to activate so many compounds inside the liver cells, and hundreds of pathways are going to show in front of you on slides, and you don't know which is driving what eventually, but that's the second hit that happens. Genes, does genes have anything to do with that? Yes, there are some genes that have been isolated nowadays. One of them is very famous gene called PMP, like picture in picture, LA3. So PMP LA3, this is one of the genes that if you have it, you are likely to suffer from damage in the liver, that secondary insult that happens and damage the liver, whether the initial problem was hepatitis C, whether it was alcohol intake, whether it's fatty liver. So there are some people who are built with a certain genetic makeup that will make them likely to suffer a second hit in their liver if they have that particular gene. So what is the presentation? How do I see patients? I mean, I'm 100% sure that if I look in this hotel right now that I'm going to find patients with fatty liver disease. But how do those people come to my office? Those people come to my office being referred by a primary care provider who noticed that the liver enzymes are abnormal. Or that patient had an ultrasound or a CT scan and the report came back saying that this patient has fat in the liver. So what about those two things? Are those accurate ways of diagnosing fatty liver disease? And the answer is no to both. Number one, abnormal transaminases or abnormal liver enzymes, they are not really specific. So when somebody is sent to my office, I have to do all kinds of tests to try to make sure that this is not something else. This is not hepatitis C. This is not autoimmune hepatitis or this or that. So that's number one. Those are not very specific. I have to tell you something that only about maybe 8-9 years ago is when we knew what a normal liver enzyme level is. And I remember this day we were in Boston in the liver meeting, and all of a sudden all the buses in Boston and all the signs were saying, that we have the normal values for liver enzymes. Before that, the liver enzymes, and up until today, by the way, the liver enzymes are reported in the wrong way. A normal liver enzyme for a female is 20 or less. A normal liver enzyme for a male, for a normal male, is 30 or less. Okay? Remember those two numbers, 20 and 30. If I open any report in my office right now that reports liver panel for me, all of them are going to say the normal goes up to 45 or the normal goes up to sometimes 50, which is not normal. That's twice the upper limit of normal. Which means what? Which means that there are some patients who are going to be going to have a blood test and the lab is going to report their blood test as being normal when they really have twice as high liver enzymes. The person who trained me in liver disease used to tell me that the normal value of ALT, AST used to be determined by the need in the blood bank. So because we didn't have a test for hepatitis C, we used to say if you have a certain number of ALT or AST higher than that number, we cannot take your blood because you could have hepatitis C. We didn't know that hepatitis C at that time. We used to call it non-A, non-B. So every week they will get a report from blood bank, we need more blood. There is shortage of blood in the United States. So we bring up the level of the transaminases. So now it's up to 65 is considered normal. And believe me, that was the case up until the 70s. And it's only in the last probably 8 years that we knew that the normal level for ALT and AST is 20 or less for females, 30 or less for males. Ultrasound can't tell you really whether this, what they are looking at, is fat or is it scar tissue in the liver. Because what they see is a higher or a denser liver, increased density of the liver. So they say, oh, it could be chronic liver disease, but it could also be fat. So when the ultrasound report says fat in the liver, it's never really truly 100% fat in the liver. It could be something else. Ultrasound report cannot tell me if this liver has tons of fat or halfway full of fat. Okay, so it's not quantitative way to tell me how much fat there is. And the other thing is it's not really sensitive. So if I have like maybe 10% of my liver has fats, increased amount of fat, the ultrasound will read it as normal. Same thing for CT scan. CT scan also has all the drawbacks of ultrasound, and on top of that, it exposes the patient to radiation. So we don't like these two tests to evaluate our patients. A lot of times, people are sent to me because they went to have like gallbladder surgery, and the surgeons opened up the patient, and everything looked perfectly normal. The patient looked very healthy. All his labs were perfectly normal. They open up the patient, and boom, they look inside, and there is cirrhosis inside. And the patient is sent to me because cirrhosis was found at the time of the surgery. And you look at that patient's probably diabetic, probably was overweight for several years. And it's not that the diagnosis was missed. The diagnosis was extremely hard to make, because with this disease, there is no symptoms whatsoever. People don't have pain. People don't have any way of knowing that something wrong is going on in their liver. So they are happy, and this is not a disease of very high transaminases, so you could possibly go and get your blood test done every year, and your physician will look at it and say, oh, everything is checking out all right, but you have been walking around with ALT and AST of 40 and 45 for so many years, and that's twice the upper limit of normal. So that's how those patients are missed, and we used to call those patients in the past, we used to call them patients with cryptogenic cirrhosis, which means that we don't know what's causing the liver disease, but nowadays we're 100% sure that the vast majority of those patients, they have fatty liver disease. So we really need more accurate tests, and there are so many blood tests that particularly can look for scarring in the liver, and that's important because it is those patients with scarring in the liver who are going to progress and develop cirrhosis, and going to progress and develop cancer in the liver. People with only fat in the liver, they are probably going to do okay. So if we have a test that tells me that this patient has scarring, then this is a valuable test for me. And this could be a biomarker, something that you're measuring in the blood, or something that fancy that you are doing in your research lab, or it could be through imaging with techniques that I'm going to talk about briefly right now. So one of them is called FibroScan, and there is another technique called MR based, like an MRI study, and there is the MR-PDFF, or MR spectroscopy, or MR elastography. So let me show you just little examples of these things and show you how it works. So this is the FibroScan. This is a very simple portable machine that we don't have in the Imperial Valley. I know that Dr. Hussein, when he comes here, he brings his own machine to Dr. Sullivan's office, and he can measure liver stiffness with this machine. So when the patient would lie down, put his hand behind his head like this, that opens up the spaces between the ribs, and then with this probe here, with this black thing in the probe, they put it between two ribs, and they send a shock wave to the liver. Now, don't believe that sending a shock wave to the liver is going to make the patient scream. It's actually something that you will not feel. You will just feel like a tap on the skin like that. And they do this 10 times, and by doing this, there is an area of 3 centimeters in the liver that the machine can read how much fat there is inside that piece and how much scar tissue there is. And this is how the report would come. And this is how much scarring or how much fibrous tissue there is in the liver. It's measured in something called kilopascal. And this is how much fat there is in the liver, and that measurement is called the CAP. And this is a very accurate test to the degree that we can tell who has advanced fibrosis and who doesn't have advanced fibrosis, who doesn't have advanced fibrosis. In other words, I can tell who are the patients who are about to develop cirrhosis, and those are the patients who are going to get the complications. Those are the patients who are going to develop the cirrhosis or bleed from esophageal varices or develop ascites. So those are the ones that I'm going to be concentrating on, and my guess is when the newer medications that are going to be available, hopefully in the next couple of years or so, they are going to be expensive medications. And I don't know if you know this or not, but based on the numbers that I showed you earlier, we are going to have, if we say the incidence of hepatitis C or the prevalence of hepatitis C in the United States is 1.5%, and we have like 5 million people, we're going to have 25 million people who need to be treated for fatty liver disease, easily. So then the question that will come is, if you're going to use an expensive drug and the patient is not going to change his lifestyle, then who are the ones you're going to really treat? Are you going to treat everybody? Are you going to treat people who have advanced fibrosis and about to become cirrhotic? And my guess is the FDA is going to say yes. this is going to be the group that we're going to treat. So this machine, if you use a certain kilopascal of 9.5, anything less than that, those people don't have scar in the liver and they don't need to be treated. Anything above 9.5, that means that they started to have scarring of their liver. If they are above 12 and a half, they have portal hypertension, they have veins in their food pipe that are about to bleed, they could develop ascites. So this machine can tell us where we are. Now if you have $1 million, not $1 million, actually multi-million dollar, and you want to buy something that gives you more colored pictures, then you get one of those machines. And that's what they have in certain centers in the United States, not in every center in the United States, because it's not a regular MRI, it's a very fancy way of doing MRI spectroscopy and MRI elastography. UCSD, they have this machine, and one of Dr. Hassanein's former students is becoming now the United States and probably one of the world authorities on fatty liver disease. His name is Dr. Rohit Lomba. And Dr. Lomba has this machine, and all the studies that are being done nowadays on patients with fatty liver disease, they request those kind of measurements, because this machine can tell you how much fat there is in the liver, how much scarring there is in the liver, and where in the liver. And when I put you on treatment, I can tell if the treatment is doing an effect or not, how much scarring is going away, how much fat is going away. So the MRI-based studies are going to be gold standards for evaluating drugs, or it is the gold standard right now for evaluating drugs. So how do we treat patients with fatty liver disease? So this is the fun part of the topic, because really we cause this to ourselves. We cause the foie gras, so we are the one who can undo the damage. And how can you undo the damage? By losing weight. So how are you going to lose weight? Well, there are so many diets, and we're going to talk about one of them. The diet itself is not that important, because if you really stick to a diet, you're going to lose weight. The problem is compliance. The problem is we're going to stick to a diet a certain period of time, and then we're going to reverse back to the way we used to eat. So this is going to be an important thing to think about. Studies that were done that showed that frequent visits to the physician or some sort of a communication with the health provider will improve the compliance with the diet. In other words, if I see my patient once a year, he is not likely to stick with the diet. If I see him every couple of months, there is a very good possibility that the patient is going to stick to the diet, because he's afraid of what's going to happen when he steps on that scale in my office, and he knows that he's going to... I'm a very kind person, by the way. I never really blame patients for what they did, but I always encourage them to continue their effort to lose the weight. But people are afraid that they are going to be told that he didn't follow the diet, so if they are seeing or more frequently, they are going to stick to the diet. There are some studies that show that if you send them text messages like 3 times a week, they end up sticking with the diet better than somebody who's not even getting any text messages. So there's something to think about. And then exercise, I'm going to talk about exercise in a second, and then there are the endoscopic intervention and bariatric surgery. So I'm just going to skip the diet and exercise, because this is what I'm going to spend more time on. I'm going to talk about endoscopic intervention. Endoscopic intervention, nowadays we can make patients lose weight doing things with the scope. So we can put an intragastric balloon. And basically we're putting a balloon and we're insufflating this balloon with either air or water. And by doing this, we are occupying the volume of the stomach with something. It's not only that there isn't enough space for the food to come in, but just the act of distending the stomach decreases the chemicals that our stomach sends to our hypothalamus, to our brain, to tell us that the stomach is empty, I'm hungry. Go fetch me some food. This is substance called ghrelin, and this ghrelin will tell the hypothalamus we are hungry. If I distend your stomach, then the stomach stops making ghrelin. So if I put the balloon, that you get that effect. If I tighten the belt around you, remember tighten the belt? If you tighten the belt around the stomach, you get the same effect. So you also decrease the amount of ghrelin coming out of the stomach, and that would make the brain feel like the person does not need to eat at that point in time. Problem with the balloons is you cannot leave them inside the stomach for more than 6 months. Second problem with the balloon is it's expensive. So it's not covered by health insurance, and an average center, I'm not talking about Cedars-Sinai or things of that sort, I'm talking about Pioneers Memorial Hospital. If you go walk over there and tell them I want to have a balloon, you have to come up with $6,000 to $7,000 to get the balloon. It's not covered by insurance, so the patient has to come up with the price from his pocket, and you're going to tell the patient, I'm going to leave it inside of you for 6 months, and you're coming back in 6 months and I'm taking my balloon away from you. You're not going to use it for somebody else, but you cannot leave it inside the stomach for more than 6 hours. How much weight do you expect the patient to lose with the balloon? You would expect the patient to lose anywhere from 6% to maximum of 10% of his body weight, which is really pretty good, because if we lose 3% of our body weight, and that's what I explain to my patients all the time. If you lose only 3% of your body weight, you lose the fat that you have in the liver. If you lose 5% of your body weight, the inflammation goes away. You lose 10% of your body weight, the scarring will go away. So that's very important for the patient to know, because I get a patient who comes to my office and he's 270 pounds. And then he looks at me and he asks me, what is my ideal body weight? And I don't want to tell him what is his ideal body weight, because if I tell him his ideal body weight, he's not going to be very happy. So I tell him, you know what, seriously, you are probably 110 to 120 pounds overweight, but I am not going to ask you to lose 110, 120 pounds. All I'm going to ask you to do is to lose 5% of your body weight. And if you can lose 10%, you are doing a great job. What is 5% of his body weight? It's about the 280 pound person. It's probably something like 14 pounds, 13, 14 pounds. So with 13, 14 pound weight loss for somebody who's 280, they get improvement in their liver histology. The liver is a quick in, quick out organ. In other words, you eat too much, the liver is the first organ that gets packed with fat. If you start to behave, the liver will be the first organ to lose its fat. And if you can push the patient and stimulate them, and very few number of people can lose their 10% body weight by themselves. Very few. Don't believe that this is an easy task. So I do a song and a dance every time somebody comes to me, and I call him the star of the day, and I congratulate him in front of everybody in my office that he listened to me, or the first person who listened to me and lost this much weight. But it's doable, okay? So balloon will cost you $6,000. Now let me tell you about another way that we can make people lose weight. You've heard about people having gastroscopy feeding tube, and there are tubes nowadays on the market that we can put in our patients that would allow them after eating to go into the bathroom and open the tube. So it's like a feeding tube, and they open it and it allows the stomach content to come out through this tube. So they had the enjoyment of eating, and then you kind of like made them vomit, but instead of like it's like an anorexia nervosa kind of thing. But so it's instead of vomiting the food, you're emptying the stomach with a tube. So I said, wow, this is really a good way to treat our patients, because I know that putting gastroscopy tube should not be an expensive thing. We do it all the time for people who cannot live because of strokes and things of that sort. So it's not that expensive. And then I asked the vendor, how much is this tube? And the answer was exactly the same thing, $7,000. So every time there is something that works, everybody else will come up with another idea, will price his product to be equivalent with the other thing. So that tube to empty the stomach will cost about, again, $7,000. But you can leave it for as long as you want. And you can empty your stomach for as long as you want. There are some other still techniques that are being developed. One of them is to go with the scope and then put a sleeve inside the intestine that will prevent your intestine from absorbing food. And then finally the bariatric surgery, which has been shown over the years to be very successful in reducing weight. How much weight do you expect to lose with bariatric surgery?
About 30% of your body weight on average will be lost with bariatric surgery. So this is a very effective way. Most of the patients, they have durable results. So a year after the bariatric surgery, the patient are still weighing the same amount, but obviously it comes with a price, and it's not something to be taken easily. Okay. So I encourage my patient to lose any amount of weight. If you lose 5%, you're getting better. If you lose 10%, you're getting rid of the scarring of the liver. So this is what I'm going to talk about. And hopefully, from now until the end of the talk, you're going to find nice pictures like this. So this is the diet that people should have been following in the Mediterranean region of the world, and they are not. And it basically depends heavily on vegetables and fruits, and also depends on fish, depends on olive oil, depends on walnuts and nuts, depends on legumes, and it also allows for milk and dairy products. So in other words, it's like a pescatarian diet, okay? So you're trying as much as possible to avoid the sugary, the refined food. You're trying to avoid, obviously, fat and meat and things of that sort. So this is the Mediterranean diet. This is probably the easiest diet for people to stick with. And remember, it is not the amount of food only that we're eating, it's what we're eating is what makes the big difference. So I tell my patients, if you're eating 3 meals a day, big plates, fill your plates as much as possible. Go buy the biggest plate you have in the market and fill it, half of it with vegetables and fruit, and then half of it with, 1/4 of it with healthy grain, and another quarter of healthy protein. You're going to lose weight, even if it's a big plate. So I tell my patients, okay, well, you guys tell me that, we eat 2 times a day outside our house and we cannot control it, so we have to stop in fast food chain. Buy the salad. Get the salad. Don't put, the excessive amount of dressing in your salad, but get salad with chicken, maybe, and avoid the bread and avoid the sweet stuff that comes with those fast food places. This is the Mediterranean diet pyramid. It tells you that every day you should be physically active. Enjoy meals with others. Nice. Every day, make your diet revolve around these foods: vegetables, fruits, whole wheat grains, olive oil, beans, nuts, legumes, seeds, herbs, and spices. That's every day. Drink plenty of water. Often, at least 2 times a week, eat fish and seafood, okay? And don't go and buy fish and chips or fry your fish, okay? So, sear it, you can grill it, and that's how you should eat your fish, okay? And then weekly, in moderation, you can have chicken, you can have eggs, you can have cheese or yogurt, and very less often eat meats or sweets. And I would say probably on a weekend when you're going out and you want to celebrate how good you were on that week, then you can add something of these things. So this is how the Mediterranean diet is structured. Don't forget the olive oil, because it's a very good source of arachidonic acid, which is very important for the health of our cells. And the fish part of it, that's your major source of protein. Dr. Oz has his own shopping list, and this is very important. I decided to include the slides because I tell my patients that once you get the bad stuff inside your house, your battle is lost. That your best bet is not to get the stuff inside your house than to try to resist that stuff once it's inside your refrigerator. At 1 o'clock in the morning, you are going to do the mistake, and your strong will evaporate at 1 o'clock in the morning, and you're going to eat the bad stuff. I just noticed that Dr. Oz said that you can get lean pork and add this to the food that you can buy. I guess that's obviously okay, but he started to change a little bit in the Mediterranean diet. The Mediterranean diet was mainly fish. Okay, so it's important that we don't buy the bad stuff and get it inside the house. The control should be while you're doing your shopping. Types of exercises. Okay. Types of exercises, there are 2 types of exercise, and that's again another battle that we fight with our patients. is you tell them, I want you to be active. And the first thing that will come out of their mouth is, okay, my back is hurting, my leg is hurting, I have this joint problem that I cannot walk, I cannot do this, I cannot do that. So the first thing that comes out is always excuses why we cannot be active. And I can understand that, because if you allow yourself to gain the weight, you are really damaging your joints. And you're going to pay a price. And you're going to have back problems and knee problems and hip problems that will limit your ability to move. But there are two types of exercises. So there is the exercise that we call aerobic exercises, and there is the weightlifting exercises. Both exercises are equivalent in terms of improving your fatty liver disease, as long as you're doing it with moderate intensity. So what is a moderate intensity exercise is? Brisk walking. So if you guys decide to go out of your house and walk 20 minutes away from your house, and then 20 minutes back to your house, and you do it 5 days a week, okay? That is all the exercise that you need to do. You don't need to belong to a gym. You don't need to buy a fancy piece of equipment. And if you're gonna tell me, oh, my foot, my hip, my knee, then do this. While you're sitting down watching TV, get weights and work with weights. 40 minutes a day, 4-5 times a week, and you've got your exercise. Equivalent levels of exercises. Could you benefit your liver if you do exercise and yet don't lose weight? And the answer is yes. So even if you don't lose a single pound, but you are actively exercising, you end up improving your liver histology. So my fight with my patients all the time is to try to convince them that this is better than this. And it's not an easy task, okay? So what are the medications that we have in the market nowadays? We have vitamin E. That's pretty much what we are using nowadays. In a very limited study that was done and published in the New England Journal of Medicine about 7 years ago, they showed that people who were not diabetic, when they were treated with vitamin E versus placebo versus this medicine, Pioglitazone, that patients who got the vitamin E, they improved their liver histology and they got better liver enzymes. I have to tell you something. This looks very familiar to me to our early days in treating patients with hepatitis C. We were using vitamin E for hepatitis C. We were using all kinds of nonsense stuff to treat hepatitis C up until the time when we found truly the medications that work for hepatitis C. So a lot of those medicines, yeah, they have a little bit of effect, they have a little bit of improvement here and there, but they are not really impacting the progress of patients with fatty liver disease. So we use vitamin E. A thing to remember is for men, it increases the chance of prostate cancer. Okay, so this is one thing to remember. Another thing to remember about vitamin E also increases the risk of stroke. So if you're putting patients on vitamin E and his liver enzymes are not getting better, probably we should take those patients off vitamin E. And the effect is very modest, it's not very helpful medication. Pioglitazone, it's one of those medications that we used to treat diabetes, came under the name Actos at one point in time, and it does help patients with liver disease, but it increased the chance of heart failure, increased the chance of urinary bladder cancer, so it's falling out of favor right now as far as the use. Liraglutide, this is one of the medications that are injectable medications. They are GLP-1 agonist. This is what you see ads on TV, that you inject yourself with something and once a week and your blood sugar level is much, much better. And you also, if you use that medication, you lose weight. So this is like Victoza, for example, that's Saxena. There are some medications that has this compound in it, and it works on the hypothalamus. It tells our hypothalamus we are not hungry. So people who are taking those medications, they lose weight. So that's one thing, and it also improves the insulin sensitivity, and it improves the condition of the liver in patients with fatty liver disease. So if somebody has an indication for its use, we tell the patients it's okay to be on Victoza. Statins is important. Why is it important? Statins is what we use to treat patients who have high cholesterol level in the blood. And all our healthcare providers, they have in their mind that statins can cause liver damage and liver disease. So when they see a patient on statin and they notice that his liver enzymes are like 40, 50, or 60, like a little bit high, they stop the statin. And that's a big mistake because statins actually improves the condition of the liver in patients with fatty liver. Number two, don't take somebody who's going to benefit from statins away from statins because statins is not causing those liver enzyme abnormalities. So every time I get a patient and they told me my doctor stopped the statin, I put him back on the statin again. I tell him, on the contrary, this is going to help your liver stay alive. Now this is one last thing here is coffee. We tell our patients drinking 2 or 3 cups of coffee every day is very helpful to the liver. And this is true. It has been shown, has been published. The effect is very modest, but it works. So if you tell them about the diet, the exercise, drinking coffee, and I also tell my patients, make sure that you're sleeping enough number of hours every night. You will all notice that when you don't sleep well one night, you stay all night awake, you're studying or playing, the following day you're going to eat much, much more than on an average day. And why is that happening? Because when you're staying up late at night, not getting enough hours of sleep, you're raising all the stress hormone levels in your blood, and raising the stress hormone levels in the blood like adrenaline and glucagon and those things will oppose the insulin and will make you eat more. Finally, I'm going to tell you that there are several drugs going to be coming to treat patients with fatty liver disease because now we understand the magnitude of the problem and how bad it is. And those medications are not approved yet. A couple of them are in phase 3 trials. And I'm not going to bore you with the names, but one of them is a medicine that we have nowadays called Ocaliva or obeticholic acid. And the second one, we don't have it nowadays, it's still in phase 3 trials called elafibranor. But those medications, they are gonna really have a good impact on patients with fatty liver disease, those who needs medications, those who are approaching cirrhosis. Those medications can help at least 30% of those patients and improve their liver functions. I'm gonna stop right here, and if you have any questions, you can ask me. Do you guys know that as of February of this year, with the registration site with the US government, there are 470 trials, 475 trials of medications being tested to treat fatty liver disease. So this tells you how much interest there is, and if you are a stock buyer, if you want to buy stocks, now that Dr. Solomon is here, if you want to buy stocks, to me this medicine really looks very good. Why? Because it's not only improving all the parameters of fatty liver disease, but it has a very favorable effect on the heart and on the cholesterol. And so unlike obeticholic acid, patients receiving obeticholic acids, they will have high LDL levels and they need to be on a statin to alleviate that. But people, elafibranor, everything gets better. I don't even know the name of the company that makes this medicine, but it's not approved yet in the United States or abroad. It's still being tested.
I'm wondering about a patient mindset. So if a patient has diabetes, fatty liver disease, and they do the weight loss to manage their diabetes, do they really kind of ignore the fatty liver because it just takes care of itself, or do they realize that they have 2 chronic conditions and they really seek out information on both, or do they just kind of ignore one?
So this is a very important question, because there are, the focus of the patients with diabetes is how is my hemoglobin A1C doing? Is my hemoglobin A1C under control, not under control? How is my blood sugar doing? But the vast majority of patients who are on treatment for diabetes, they actually gained weight, or they are keeping their weight the same. They are not exercising, they are not eating right. So really they have not come down to the root of the problem. Whereas if you look at somebody who has diabetes, high blood pressure, high cholesterol level, fatty liver disease, who undergoes gastric bypass surgery, for example, and they lose 30% of their body weight, all those medical problems will disappear. So the problem is not the diabetes, the problem is the lifestyle that was lived for so many years that damaged all those organs. And to me, yes, you can take care of your blood sugar level, but you are not really doing anything to correct the source of the problem. So changing the lifestyle, walking 5 days a week, 20 minutes away from your house, 20 minutes back to your house, and eating sensibly, not restricting your calories, but eating the right food is all what we need to get rid of all those problems. And if you truly lose the weight, you are going to get rid of all those medical problems.
Just exercise, lose any weight, and deliver it. But there is a fluctuation also after the liver. So it's not necessarily that the liver is
So this is the major problem, as Dr. Salman was saying, is we really don't have a test, a proper test at this point in time that we utilize in the community to tell if the liver disease of the patient is getting better or not. If you don't have this fancy MRI machine that shows you that the amount of fat in the liver has come down, then you can't tell, because a lot of times whether the patient is losing weight or not losing weight, their liver enzymes today is 50, next time is 37, and the time after that is 42. Now, was he really doing better when he was down to 37? I don't know. I mean, there are some people with frank cirrhosis of the liver who have perfectly normal transaminases. So this is not a disease that you can judge based on the level of transaminases, whether it's getting better or getting worse. We need more accurate tests that tells us what's going on in the liver. Again, very reminiscent of what happened in hepatitis C. When hepatitis C, we didn't have a test that checks for the HCV RNA, the RNA part of the virus in the blood. We used to count on AST and ALT, like blood liver enzymes, to tell whether the patient is getting better with treatment or not. And all those medical papers that were published in the finest medical journals are now considered a piece of junk, because they didn't mean anything. They were just following the transaminases, and patients with hepatitis C with transaminases up and down all the time. Same thing with fatty liver disease, up and down all the time. So when we look at a patient and I tell him, congratulations, your liver enzymes are lower than 6 months ago, you're doing a good job, I'm really fooling the patient, because I don't know what's going on inside his liver. But, you know, I can come up with stories about people who I followed over the years for fatty liver disease, and I lost to liver cancer. And it's very sad. It's very sad to see somebody in front of your eyes over the years, and you're telling them, you know, you better do this, you better do that, and they show up every 6 months to your office, and they are trying really to lose the weight, but they can't. And then one of those visits, you're doing a blood test or an ultrasound or an MRI, and you tell them you have cancer in your liver. That is very, very hard for everybody. You guys have been wonderful. You've been great. I think we should give you like gift certificates from the mall here, right? Or